My name is Dawn Prahl-George, and I'm the Executive Director of the Macula Vision Research Foundation. And I couldn't be more happy to be here in Phoenix and seeing all of you than ever. And there's a couple reasons for that. The foundation is in existence because we're working to find a cure for macular degeneration and other retinal diseases, which I know many of you are impacted by, suffer from, or your loved ones do. So we're thrilled to be here to talk with you, and hopefully you'll learn more than you already know about the disease. You'll learn more than you already know about how to cope with it, and you'll learn more about the cutting-edge research and the prevention and treatments that are out there. I'm also really happy to be here today because it's snowing like again in Philadelphia, which is where we're from. So that alone makes it also very much worth it. Without further ado, I want to show, if I'll get my colleague here to start the video, we want to show a very short video to you about our foundation. I'm not the star attraction. I'm just going to moderate. We've got a panel of experts here today who are the stars who will impart a lot of information to you.
Macular degeneration is slowly robbing the sight of 11 million Americans. By the year 2020, this number is expected to be more than 20 million people. But we see a clearer future. We know a cure is on the horizon. Over the past 20 years, MVRF has given $20 million to the top scientists conducting the most credible and promising research around the world. For decades, macular degeneration was a mystery, something that happened to people as a part of aging. Now, because of MVRF-funded research, scientists know the nature of AMD. They are pioneering leading-edge genetic discoveries, plumbing the very depths of this devastating disease. Our work is fueling even more discoveries. Through gene therapy, we are now reversing childhood blindness and continue to make headway in advanced treatment methods for wet and dry AMD. We see macular degeneration going the way of polio and smallpox, a relic of the past, a footnote of history. We believe we're closing in. We're working every day so millions of people can keep their precious vision. It's the reason our founders, the Lotman family, started MVRF, where 100% of every dollar donated goes directly to research in the field. That's a vision we can get used to. That's a world we can believe in. Because believing is seeing. MVRF is a 501c3 public charity, and we rely on support from believers like you. Thank you. Macular degeneration is slowly robbing the sight of 11 million Americans. By the year 2020, this number is expected to be more than 20 million people. But we see a clearer future. We know a cure is on the horizon. Over the past 20 years, MVRF has given $20 million to the top scientists conducting the most credible and promising research around the world. For decades, macular degeneration was a mystery, something that happened to people as a part of aging. Now, because of MVRF-funded research, scientists know the nature of AMD. They are pioneering leading-edge genetic discoveries, plumbing the very depths of this devastating disease. Our work is fueling even more discoveries. Through gene therapy, we are now reversing childhood blindness and continue to make headway in advanced treatment methods for wet and dry AMD. We see macular degeneration going the way of polio and smallpox, a relic of the past, a footnote of history. We believe we're closing in. We're working every day so millions of people can keep their precious vision. It's the reason our founders, the Lotman family, started MVRF, where 100% of every dollar donated goes directly to research in the field. That's a vision we can get used to. That's a world we can believe in, because believing is seeing. MVRF is a 501c3 public charity, and we rely on support from believers like you. Thank you.
Thank you very much. So that tells our story, and believe me, there's a lot more to it, but I'm here to tell you that we believe there is a cure clearly in sight. Unlike cancer and other diseases, there is a cure for macular degeneration. Our scientists all around the world concur that a cure will be found in short order. So we are here because we want to provide an optimistic view to many of you, to talk with you about why we believe that, and also to explain to you that without these scientists that we gather and fund their work, we believe there would not be a cure as quickly, because our strategy is that we don't fund labs in various institutions across the world. We actually fund the scientists who are doing the most credible work with the most promise. And so we're extremely targeted. That's what makes us very different from any other foundation you may know of. We're incredibly targeted in our approach, and we get a very good return on investment because we invest in the researchers who are the quickest way to the cure. So I want to introduce, and if you have more questions, I'm going to be around. My colleague Lynn Rinaldi, who's our outreach and education coordinator, many of you met already, will be around, and we're happy to answer questions after the session. But we want to get the program underway, and I want to introduce our first speaker. Her name is Dr. Shabari Seetharam. She's with Arizona Retina and Vitreous Consultants, and she's going to be presenting a session on, it's on your program. You all have one of these here, okay? And it's the first item, AMD 101. So again, welcome to the SupportSight Seminar, and we hope you'll learn a lot more than you knew coming in.
All right. Like Dawn said, my name is Shabari Seetharam. I'm with Arizona Retina and Vitreous Consultants, so I am a retina specialist here in town. And I love talking to patients and the way our healthcare system is going. Sometimes there's not enough time to do that. So forums like these are wonderful to share what's going on. I'm going to talk, I'm loosely going to follow this outline. When we made this outline, we didn't really have the agenda hammered down, but I'm going to be covering dry and wet macular degeneration 101 and 102, I would say. So to begin, let's talk about the anatomy of the eye, because I think, actually before I do that, let me see a show of hands. How many people in here are diagnosed with macular degeneration? Okay, all right. And of you guys, how many of you guys have the wet form and are getting the shots? Okay, all right. Okay, all right, so I won't belabor these basic points too much then, because I'm sure you're aware of them, but when we look in the mirror, we all see our eye and the pupil, and through the pupil is where the light is focused. Our lens, where cataracts occur, is right behind here, and the retina is a light-sensing tissue that wraps around the back wall of the eye, and the macula is the very center portion of that. And filling this space is a collagen gel called the vitreous, and that's where we get floaters. So this is a cadaveric sample, all right, and I think this is interesting for those of you who haven't done gross anatomy. So we have the lens, and it gets cloudy when it comes out of a human body because normally our body is actually pumping fluid constantly out of this cornea to keep it clear. But once, obviously, it's been dissected from the body it was attached to, it's cloudy. Here's our lens, and here's the retina. In this specimen, you can actually see a detachment. So that's what detachments look like. They wrinkle up like that. And that's artifactual, just from the fact that they cut through the eye. We see the detachment there. So the retina is actually a clear tissue, and you can get a good sense of that when you look here. This kind of white tissue type material. It's actually clear, and that's because light has to travel through the retina to hit the workhorses of the retina, or the photoreceptors in the back part of the retina. So it goes through some neural tissue. The photoreceptors go through a chemical process to change light energy into, it changes some chemical compounds in the cells of our eyes, which is what releases a neural impulse which travels back to our brain. Underneath these photoreceptors is a very important tissue called the retinal pigment epithelium, and we'll be talking about that a little bit more when we get to different research that's going on. But the retinal pigment epithelium keeps the photoreceptors alive. It's kind of the soil that keeps these photoreceptors nourished. What nourishes the retinal pigment epithelium is the choroid, which is a vascular layer behind all this, which is constantly supplying oxygen and nutrients. And those nutrients are diffusing through a membrane here to get to the RPE. That's the acronym we use for retinal pigment epithelium. So macular degeneration is a decline in the function of the retina that's responsible for detailed vision, specifically the macula. So what makes this part of our eye so special? Why do we care about the macula? Well, it is in the center of our eye, so it has a unique position. It has special cells in this part of the eye that aren't as plentiful in other parts of the eye. It has a different retinal architecture than other parts of the retina. And this tissue is very highly metabolically active. Obviously, we're using our vision a lot, and it is this metabolic activity that leads to some of the degenerative process we see with macular degeneration. So this is a right eye, and I know it's a right eye even though if they didn't have that label there, because the optic nerve is shifted nasally. And that's because if light was to hit this optic nerve, and this were in the center of our retina, we really wouldn't see anything because there's no retinal tissue in the nerve. So we all naturally have a blind spot where our optic nerve is, and that's shifted off to the temporal sides of both eyes. It's very small, so we don't notice it on a day-to-day basis. So the macula is privileged in terms of being at the very center of the retina. And it's roughly this area. We don't have to be exact about where it is because clinically speaking, it doesn't matter to us. Even during surgery, it doesn't necessarily matter exactly where the macula is. But if you were to look at this with an electron microscope, we'd know this is the macula because it has 2 layers of ganglion cells, and those are just special nerve cells. I should mention the very center of the macula, this darkest area here is the fovea, which is what does our highly detailed vision, and within that is a foveola, and we'll talk about that in just a bit. So photoreceptors, the cells of the eye. We have rods, and we have a lot of these. We have 120 million. So it's amazing to think there's 120 million of anything in our eye. These cells are most active in dim condition to detect light and to detect motion. And rods take a little while to adapt to this dark state. So right when you wake up at night, your vision isn't quite as good as if you were to stay up for a little while. You'll start to see things moving in the shadows that you didn't see right when you woke up. Also, there's cones. So cones are the cells of the eye that are more sensitive to color and to spatial relationships. There's only 7 million of these. Only 7 million. I mean, 7 million is still a lot. They're sensitive to color. So within the fovea, and specifically the foveola, there's only only cones, no rods. So it's all about color and space, okay? Not about contrast and motion, which is what our peripheral vision does. And these cones are actually special in that they are even more skinny than cones elsewhere in the eye. So they're designed to be skinny so that they can be densely packed. And despite the fact that the fovea is such a small part of the retina, it still takes up 50% of the space in the optic nerve and 50% of the space in our occipital lobe that processes visual information. So despite the small area, it has a privileged amount of neural tissue dedicated to it. So this is a very interesting picture that you guys won't see in the clinic because this is adaptive optics. It's a type of imaging study that is not available clinically. It's only available in labs, and it's probably going to be another 10 to 15 years till we optimize it to actually work in clinics. What we're looking at here is light that's shining back out of the cone cells. So all these little speckles back here, and I know the contrast in here is not ideal, but all these little speckles is light that's being reflected down through the cone and back at us. And where there's a shadow, that's where a blood vessel is. So in the future, our hope is that we will actually be able to map cone cells and see, at the level, at the cellular level, how much progress is there with the macular degeneration. But I picked this picture because I thought it'd be interesting for you to see some new technology that maybe we'll see in 15 years in the clinic. This is kind of like what OCT was to us in the early 90s. We didn't have an OCT. But when you take a sample near the fovea, you can see how densely packed the cone's here. When you go even further away from the fovea, you can see that there's a little more space. So those cones are really densely packed in the fovea, which is the center part of our macula. So the architecture of the macula is also different. There's no blood vessels right in the center of the macula, and that's on purpose to decrease the amount of diffusion of light from the blood vessels. And the neural cells, which are the ganglion cells, are actually, there's a 2-to-1 relationship, whereas in the periphery, actually some photoreceptors don't even get a single ganglion cell dedicated just to it. So there's high fidelity of transmission of information from the fovea to the brain. And the macula has yellow carotenoids that build up and act as a UV filter, and we'll talk more about that in a bit. So this is the OCT, or optical coherence tomography scan that I mentioned. And how many of you recognize this type of scan? Yeah. So this is actually looking at the retina in cross-section. So if the retina were like a birthday cake and we slice through it, these are all the different layers. This depression right here is the fovea, and this is a very normal and healthy-looking retina based on this OCT scan. This black empty area is the vitreous gel that we talked about. Below here is that choroid blood layer that we talked about, and this bright red line is that retinal pigment epithelium. And this is a drawing to kind of illustrate that, the fovea and the perifoveal area. So those are nice and healthy maculas. So what happens with macular degeneration? Well, the hallmark of this disease are drusen, and that might be a word that's very familiar to you. So all these yellow spots that are building up in the retina are drusen, and this person actually would be considered to have early macular degeneration because these drusen are on the small side. These are also drusen. They look a little different. They're a lot larger, and some of these, like these bright areas here, some of those are becoming calcified. And this person has intermediate macular degeneration. So what does that tell us? Well, if the right and the left eye looked identical in this patient, we could say that in a 5-year period, the chance of developing advanced macular degeneration is about 0.5%. This patient, however, when we look at both retinas together, we could say that this patient may have a 12% chance of developing advanced macular degeneration. So just the clinical exam alone, looking at the retina, and you don't even really have to take a photograph. You just have to hold up a lens and look at the retina. It doesn't cost a lot. It's non-invasive. We have a lot of predictive information about what's going to happen to these eyes or what could happen to these eyes. So when you think about dry macular degeneration and these drusen, I like to think of the photoreceptors kind of as blades of grass, and these drusen are kind of like mounds of dirt underneath it. So all these blades of grass look pretty healthy, and it looks like this grass is surviving just fine. Same thing on this OCT. So if you go back to this patient, they probably may have 20/20 vision. I don't see any signs of wearing away of the retina or any other troubles that this patient could have. So they could be walking around and not even know they have macular degeneration, but technically they do. You do not have to have a decline in your vision to be diagnosed with macular degeneration. You just have to have these hallmark signs. Drusen are the most classic sign, but some very rare patients can have just pigmentary changes without drusen, and that's when it gets a little tricky for the retina specialists. We start entertaining other disorders as the cause of that, but most of the time we see a lot of drusen. So where are these drusen located? These are the photoreceptors. This is that retinal pigment epithelium. There's that choroid vascular layer. So it's that membrane, this semi-permeable membrane that allows oxygen and nutrients to diffuse through here where the drusen build up. So what's in them? It's fats, proteins. We find actually some immunoglobulins or proteins from our immune system within here. We find some cells that create scabs and scarring called fibrocytes in here. We find some of the proteins that we actually find in the brains of patients with Alzheimer's. But there is been a lot of speculation of if Alzheimer's and macular degeneration are related, and they are not. There's been some conflicting reports on that, but a major study came out in December from Australia, looked at 7,000 patients, and they did not find any statistical correlation in that. So as these drusen develop, they block this transmission of nutrients and oxygen through the layers, and eventually we can have some death to the RPE cells. And when an RPE cell goes away, so does its associated photoreceptor. And that's when we get areas of atrophy. So we're seeing islands here where we see tissue missing, and that's advanced macular degeneration in the dry form. And this is another example of atrophy progressing through the years into a larger area. So what can we do for dry macular degeneration? Well, we, back in the early 90s, did a trial to see if we could laser away these drusen. Would that help? Well, actually, it caused more damage than good. It actually increased the advancement of macular degeneration to the wet form. So we decided we're not going to do that anymore. AREDS 1 and 2, which we'll talk about a little bit more, show that antioxidants and zinc are helpful. They slow the progression of macular degeneration. They don't reverse it, but they do slow the progression. And the mainstay of preventing and treating and slowing down macular degeneration is lifestyle. So if you're smoking, stopping, or if you don't smoke and you've been diagnosed with macular degeneration, don't start. Maintaining a healthy weight. There is some thought that fats and cholesterol issues and just having more fat tissue in the body is pro-inflammatory in a way. And there are some inflammatory cycles that occur with macular degeneration. So that's why maintaining a healthy weight is important. And controlling blood pressure to avoid any of the ischemic changes. Ischemic meaning poor blood flow to the retina. We want to keep the blood flow as as robust as we can to the retinal tissue. Diet is very big, so decreasing the amount of saturated fats in our diets, eating a lot of phytochemicals, and that's just colored pigments from foods. So phytochemicals would be, the dark greens that we've all heard about, but also brightly colored berries, carrots, trying to eat the rainbow, as a lot of doctors say. And then eating fish, patients that eat fish, we've found that they have a lower incidence of macular degeneration. However, interestingly, the AREDS 2 study did not find that adding fish oil to the supplement really changed the outcome. But yet, we do see that patients who eat fish do have a lower incidence of macular degeneration. And omega-3s have been found to be helpful in terms of keeping the rods, those photoreceptors, healthier. So even in other degenerative disorders like retinitis pigmentosa and Stargardt's disease, we do recommend keeping up with omega-3 intake. So what's new on the horizon for macular degeneration? Where there's a medication in the pipeline called Acusella. It's in phase 2/3 trials. And so phase 1 trials are where we just see if the medication is safe. Phase 2, we see if the medication's actually working, and we keep an eye on safety to make sure there aren't any big safety concerns. Phase 3 is the big trial where we actually compare the investigational drug or investigational treatment to the current gold standard. The current gold standard in macular degeneration is just, AREDS. So this is an oral medication, and what it does is slows the visual cycle, and we'll get to a slide in just a second that explains that a little better. And so far, back in December when I checked, the goal was to have about 440 patients enrolled, and there's been about 50% or so. And I should say, you know, you'll hear a lot about trials. Phase 2 trials is phase 2 is the #1 stage of clinical trials where a trial actually does not meet its endpoints. So if you don't meet your phase 2 endpoints, you don't go on to phase 3. If you're not at phase 3, you're not going to get approved to be a treatment or medication for patients. So we hear a lot about trials, but a lot of them stop because they don't meet certain endpoints along the road for FDA approval. So the visual cycle is when light hits photoreceptors, the visual pigment in the cell changes chemically to a different chemical structure, and we're actually getting vitamin A through the choroidal circulation, through our blood flow, and that's actually being converted, and it's here in a certain step of the visual cycle that oral medication is actually stopping the visual cycle. Well, why would you want to do that? Well, because the visual cycle does have some toxic byproducts, and the retinal pigment epithelial cells down here typically do take away these toxic byproducts. However, in macular degeneration, that's slowed down, and so if we can slow down the production of these toxic products, perhaps we'll slow down the degeneration of these RPE cells. Now, is that going to have an impact on one's vision? Possibly. Obviously, they're going to be looking at that in this trial, but we do have far more rods and cones and far more rod and cone function than we really need. Lots of patients with, I shouldn't say lots of patients, but many patients with retinitis pigmentosa have decreased rod function, but yet can still have 20/20 vision. The complement cascade, we hear a lot about this in medicine. So complement proteins are proteins from our immune system, and it's a series of, it's a cascade, meaning after one protein gets set off, it's a chain reaction. And these proteins are designed to create holes in cell membranes, and that's how we destroy bacteria or organisms in the body. Well, the complement cascade is upregulated in macular degeneration. We've seen that in a lot of studies. So lampalizumab is a new medication that's being studied to halt this complement cycle. And it has met its phase 2 endpoint and is now in phase 3. And its endpoint was to look at this area of geographic atrophy to see if it could slow down the increase in the size of geographic atrophy, and it actually did a very good job at that. And actually certain subgroups that have certain complement genetic polymorphisms actually had a 54% reduction. So this is an injectable medication. It is intravitreal injection. So I know everybody with dry macular degeneration has not had a treatment so far that like the wet macular degeneration folks with injections, but this is a possibility. And specifically, this medication is an antibody against one of the complement factors, specifically factor D. So the eye vitamins, we had AREDS that came out, age-related eye disease study, and AREDS 2 came out in May of 2013. Basically, we've cut out the high-dose vitamin A portion of things because it really wasn't found to make much of a difference, and it actually has some deleterious effects in certain patients who have smoked in the past. And the zinc component, you know, they found that increasing or decreasing it really didn't make a difference, so they kept it at 80. But the main things that were changed were adding lutein and zeaxanthin, which are some of those carotenoids we talked about that build up in the macula and act like a UV filter. You know, you'll see a lot of eye vitamins and supplements at the drugstore. Not all supplements are benign, so just keep that in mind. You want something from a reputable company. Ask your doctor for a recommendation on different formulations because there's a lot of them out there that are not actually adhering to these recommended dosages. And this is just an example of some, you know, supplements people may take that actually do have harmful effects on the body. I won't dwell on that too much. So wet macular degeneration. That is when we see fluid or blood building up in the retina. And on this OCT scan, we actually see this is the choroidal neovascular membrane. This is some fluid, subretinal fluid, underneath the retina. That blood is not coming from the retinal vessels we see on the surface. It's not coming from these retinal vessels. It's coming from the choroid, which we've talked about a couple of times now, the vascular layer underneath the retina, it's breaking through that Brooks membrane and coming up underneath the retina. So this is what happens. Wet macular degeneration that's not treated can become a disciform scar. So this is basically how the eye forms a scab. Once we have the disciform scar, unfortunately we don't have any treatments or medications to get rid of that. There are some low vision tools out there that Dr. Noon will talk about, and the intraocular telescope that we'll also talk about in a bit. So intravitreal injections are the mainstay of treatment for wet macular degeneration. This is the gold standard, and the gold standard is Lucentis, and that's because that's the FDA-approved medication. Patients may need indefinite treatment, to be honest. I mean, everybody asks, how long will I need treatment? But we cannot, guess that. Some patients we can treat for a while and kind of just watch, and oftentimes there is recurrence, and so we need to stay on top of this disease. There are more durable treatments that we're working on and are in the pipeline, and we'll talk a little bit about the past of wet macular degeneration. So again, we turned to laser back when that's all we had, and that actually kind of worked better for wet macular degeneration than dry macular degeneration. So what we would do is actually coagulate those blood vessels that were breaking through the retina. So this didn't cause anybody to gain any vision, but it decreased the amount of severe vision loss. And, even nowadays, on very rare occasions, you can employ this type of treatment for patients who may have one of those vascular membranes that's not right underneath the fovea, but a little bit more off to the side. PDT is a cold laser that was popular in the 90s. I'm going to kind of rush through this. Now, anti-VEGF. So VEGF is a cytokine that promotes angiogenesis, or new blood vessels to form. So any inflammatory and ischemic environment can promote this cytokine to be released into the retina and actually into the vitreous cavity. So we have found doing studies that patients actually also who are diabetic have higher VEGF levels in their vitreous, and also patients with macular degeneration. And so that's how the whole research started to look at what anti-VEGF medications we could use. Macugen was the initial one. However, its results didn't have anybody with visual gain. Again, just like laser, it slowed the amount of visual loss. The Marina study was a landmark study in ophthalmology, and that looked at patients losing vision with Lucentis versus sham, or actually versus PDT. And or sham injections, I should say. The results for this were actually pretty amazing, and I'll just go through all of them here real quick. In terms of visual acuity gain, patients who were injected had an average of 7-letter gain at the end of 2 years. However, patients injected with the sham treatment had a 10-letter loss, so almost a 20-letter difference between treating and not treating. And so that's something we don't talk about a lot with patients when we're initiating treatment, is that doing nothing for these vascular membranes, on average over 5 years, about 2/3 of patients will lose 5 lines of vision. So if you're kind of, annoyed that you're going to have to go get an injection again, well, the alternative is doing nothing, and that, has its effects, and that's something we don't talk about a lot with patients. Even though if vision is remaining stable with injections, that's really our main goal, but preventing major vision loss is a real boon with this medication. Avastin is a similar anti-VEGF. However, it was initially used for colon cancer, and now we only use a tiny aliquot of the 400 milligram IV bag to use in the eye. Therefore, it is much cheaper. It is safe, and the comparison of age-related macular degeneration treatment trial proved that it was safe and that it was comparable to Lucentis. So Avastin and Lucentis, there's really no difference in using those medications for treatment. Now, on an individual basis, some patients do better with one drug than the other. But as a whole, when you compare the medications, there's no large difference. There's also Eylea, and we'll just talk a little bit about that. In this CAT study, as we call it, at 2 years, 50% of patients still had fluid on their scans despite getting monthly injections. So a recent study took those those patients who still had fluid with the standard treatments of Avastin and Lucentis and switched them to Eylea. Well, Eylea is not a panacea. It's a new medication and it can work really great, but still 80% of those patients with persistent fluid still had persistent fluid with Eylea. So it's not a cure-all, but it's one more drug in our armamentarium. There are some adjunctive medications in the pipeline. So something called Fovista is something that you use with Lucentis, and it actually has found that patients have an even greater visual increase. It's in phase 2 and it's starting phase 3 trials now. And these patients have actually needed less injections of Lucentis. Other adjunctive therapies are also in the pipeline, and some oral agents that are used for cancers have been we're starting to study them a little bit for macular degeneration. Radiation for macular degeneration is something we have tried. It hasn't panned out to have great effects. There was something called the Cabernet study that looked at waving a radiation wand over the macula, because radiation has an anti-fibrotic and an anti-inflammatory effect. However, this did not meet its phase 3 endpoints, and this Oriya radiation is something that was published in some European, or not even published, it was presented at some European meetings, but it's definitely not something that we're using in the US, but just an idea to give you that we are trying to look for alternatives to injections, but radiation is not quite there yet. The genetics of AMD, I'm sure patients or people have a lot of questions about this. At this time, the American Academy of Ophthalmology is not recommending genetic testing for a number of reasons. There are a lot of genes that we have found that are associated with macular degeneration, many in the complement cascade. Some of them have to do with the extracellular matrix, and the extracellular matrix is just the glue that the photoreceptors in all our cells live in. And just to look at the complexity of all the different proteins involved in the extracellular matrix, there's a lot. So there's a lot still to be done with figuring out exactly how these genes work. But in terms of genetic testing, the bottom line is, at this point, just looking in the eye and clinically determining what one's risk is for advanced macular degeneration is comparable to the genetic testing that we do now. So doing genetic testing doesn't add much to what we already know. It's not helping us predict macular degeneration any better. We don't have any treatments that are tailored towards certain genetic polymorphisms, and but that may be changing in the next 5 years or so. But at this point in time, you know, it's sexy to offer genetic testing to patients in the office, but you know, we have to use healthcare dollars wisely. And if it's really not changing anything in terms of patients' management, at this point, we're saying let's just hold off until we have more data. And I know the foundation is definitely working on, you know, more research towards finding exactly which genes are helpful to test for, and which genes kind of make people more susceptible to the disease, and which genes may actually help people you know, be susceptible to certain treatments. So with advanced macular degeneration, you can get a scotoma, and this would be a severe scotoma. Now, the vast majority of people out there have early macular degeneration, and 50% of patients with early dry macular degeneration will not go on to have any advancement towards advanced macular degeneration. But I know there are maybe some of you out there with a scotoma like this. Well, what can be done for that? Well, there are intraocular telescopes out there, and I'll let Dr. Noon talk about this a little bit more. Okay, it's inserted much like cataract surgery, so if you've already had cataract surgery, this is not something we're offering at this time. But keep in mind, this implant is about 6 times as large as a typical cataract implant. And you have to have some certain you know, ophthalmic requirements in terms of how healthy your cornea is, and whether or not you've had any troubles with your retina. Stem cell therapy is something that you may have heard about. Back in 2012, some preliminary data was released, and really there's only 2 patients that we heard about back then, and in terms of their visual improvement, it was plus or minus. It wasn't really robust, but this is the first ever stem cell trial in humans, so it's exciting for science in general. And there's also gene therapy on the horizon for macular degeneration, and a company called Genzyme is working on inserting a protein into our retinal cells which will actually downregulate the production of VEGF, that vascular protein we talked about that promotes angiogenesis.